All right, ladies and gentlemen, I want to present to you an interesting case. I'll give you a chance to look it over. Now here's the CT chest, and we're going from the top down here, so look at things like that. Any part of the chest here is fair game. I hope by now you've familiarized yourself pretty well with the anatomy. And so remember, the key process is to look at a set of images like this and identify what kind of abnormality is present, or abnormalities, and be able to describe the anatomy that is involved with the abnormality. Okay, and then we'll try this in a lung window, see if there's anything else going on worth seeing here. Okay, and let's try another plane. Okay, if you hear some noise in the background, I'm at my local favorite coffee shop. Oh, this is very interesting, isn't it? Very interesting. All right, so look at that on lung windows. Not a whole lot going on in the lungs, okay? I will give you that this is a patient with a pleural effusion, okay? So we have pleural fluid on the right. Pleural effusion really should mean watery fluid, but it is used generically, more than I think it should be, but the fact is it is. It's used generically for any fluid in the pleural space. So people will say that if someone who's had trauma and has fluid in the pleural space, which is clearly hemothorax, they will say there's a pleural effusion. In fact, there are people who will call it a post-traumatic pleural effusion. Okay, so look at the anatomy here. I'll draw your attention right away to the vascular system. And looking here at the heart, what do you see that surprises you? Look at the discrepancy here between the right ventricle and the left ventricle. And look at the discrepancy between the right atrium and the left atrium. Okay, this is a good view of right atrium, right ventricle, left atrium, left ventricle. Okay, looks like they've had some valve prostheses placed. So what's going on? Well, besides identifying these chambers, you notice that there's an asymmetry in that the right chambers are bigger than the left. The right atrium looks decidedly larger than the left. The right ventricle looks decidedly larger than the left. You see that? Okay, and if you look down, here we're going up. If we look down more inferiorly, let's see what happens when we go out of the right atrium. We should be going into the inferior vena cava. Well, this is pretty large for an inferior vena cava. I think you can tell that. It's 4 times as big as the aorta, cross-sectional area at least. And then if we go down farther into the liver, you see these structures. What are these structures? You should know at this point that those are not portal veins, they're hepatic veins. They are, as we go from the liver here upward, you will see them here and here joining the inferior vena cava. So look at that. They're joining the inferior vena cava. This is actually what they call in ultrasound the Playboy bunny sign, and it's just looks kind of more like a Playboy pig because it's got this big snout because of the dilated vessels. Okay, so this is an inferior vena cava coming into the right atrium. It's all dilated. So, cutting to the chase, you have a right atrium and right ventricle which are disproportionately enlarged compared with the left side of the heart. You have an inferior vena cava, which is very dilated, and you have distended prominent hepatic veins. Okay, what could be causing that? Well, this is a good depiction of right heart failure. This right side of the heart, for whatever reason, and you know that there's been some valve problems before, and that might have put the heart over the edge in terms of its ability to contract. But the right side of the heart just cannot pump out the blood that's coming to it as fast as it needs to. And maybe you've heard about the Starling law, which is that a ventricular contraction ability depends on how much distension of the ventricle there is. So at a certain point, when the ventricle becomes more distended than it should be, it has a greater force of contraction. So once it gets up to a size like that, it is able, or better able, to keep up with the output from the left ventricle. So this is right heart failure. The right side of the heart cannot keep up with the necessary output, and so there's a backup from the right ventricle to right atrium, and then to the superior vena cava, and that's why, even though the SVC is not really dilated, there's a slow process of emptying of the injected contrast into the SVC, and if you look here, that's why there's so much dense contrast, although it could just be poor timing of the bolus and imaging. But in this case, I think there's a significant component of slow emptying of the SVC into the right atrium because of the right heart failure. So here we're beginning to see the dynamics of the anatomy. We're beginning to appreciate the dynamics of the vascular system, heart failure. This is right heart failure. Left heart failure, of course, looks different. You see the anatomy of the inferior vena cava. And so now if you see an ultrasound or a CT abdomen and someone has got these very dilated hepatic veins, you know you might want to think about right heart failure. And also look at one other finding here. Look at the right ventricle compared with the left ventricle. See how the right ventricle itself is just larger? And you see this bowing of the interventricular septum. All words you should be very conversant with. There's bowing of the interventricular septum. And that's because of the distension of the right ventricle is greater and creating so much pressure that it's actually pushing the ventricular septum, interventricular system over. Now this is something that we usually see in another diagnosis, in another situation. What might that be? What might that be that would cause increased pressure and an inability of the right heart to empty fully? It's pulmonary embolism, because this right side of the heart, of course, is emptying out superiorly. Remember, the pulmonary artery comes off in the front here, and it empties out into the main pulmonary artery, right and left. So pulmonary emboli, which lodge in here, and in the distal branches, but especially they tend to get stuck here and there, in the distal right and left main pulmonary arteries here, that causes so much resistance that the heart is unable to empty. So one cause of ventricular dilatation like this is pulmonary embolism. And when it's caused by pulmonary embolism, this is a very concerning finding. This is not pulmonary embolism here, remember, it's right heart failure. But right heart failure can give you dilatation of the right side of the heart, and so can pulmonary embolism. But pulmonary embolism causes this displacement because there's so much pressure when this right heart contracts and is trying to push blood past those pulmonary emboli, trying to squeeze by the pulmonary emboli that we don't see here. It can't, and it's encountering so much resistance, whereas the left ventricle has very little resistance. So you get this displacement of the interventricular septum. So that can be a sign not only of pulmonary embolism, you should see the pulmonary embolism very clearly in a case like that. But when you see that, when you know you have pulmonary embolism and you see this, you should be thinking, this is not just PE. This is a PE with right ventricular strain. This is a bad case, an ominous case, a worrisome case of pulmonary embolism. That's the difference. So, once again, here we have enlargement of the right side of the heart, and in this case, it's because of right heart failure, inability of the right heart to keep up with the blood flowing into it. But keep in mind that it's very interesting to look for, this finding is very important to see this when it's present, if the patient has pulmonary embolism, because then it can be an indication of right ventricular strain, which indicates a particularly serious prognosis, a bad prognosis for that patient who is experiencing pulmonary embolism. That's all for now.